Hey, curious people, you're listening to the Self-Led in Bed podcast, where we explore our fascinating internal sexual landscapes and discover our authentic sexual selves. I'm your host, Patricia Rich, a certified internal family systems and sex therapist, coach, and creator of the Self-Led Sexuality Model for healing, pleasure, and empowerment. I've spent the last 30 years helping people to develop fulfilling relationships with themselves and others. If you're ready for some warm, smart, and juicy conversations, me and my parts invite you and your parts to get cozy and settle in. Moodiness, hot flashes, poor sleep, libido shifts, the menopausal transition, which half the world's population will experience, can go smoothly for some people, but can wreak havoc for other people's sense of self, emotional stability, and sexual satisfaction. While menopause is starting to come out of the closet in popular culture, there are still far too few medical providers who know when to bring it up, what to ask, how to listen, and what options are most helpful for the emotional, physical, and sexual well-being of their patients. Today's guest shows us how different this can be. Not only is Dr. Pebble Kranz a family physician and a sexual and menopause medicine specialist, she also is IFS-informed and brings compassionate and affirming care to her patients of all genders. I saw her present recently on her latest passion, which is helping those who fear and avoid gynecological care to have empowering and corrective experiences. And I knew that I wanted to have her on the podcast. What if all doctors could become self-led in medicine? I know you will enjoy her humor and warmth as you learn more about the stages of menopause, how it impacts the sense of knowing who we are, the systemic barriers and burdens that prevent people from getting the help they need, and how to advocate for yourself and your parts. Dr. Kranz graduated from Brown University's medical school in 2007 and completed residency with the University of Rochester Family Medicine Residency Program in 2011 with a focus on psychosocial aspects of primary care. After serving as residency faculty and a primary care doctor for the University of Rochester, Dr. Kranz pursued additional training in sexual, menopause, and gender medicine, earning fellowships from the European Committee on Sexual Medicine, the International Society for the Study of Women's Sexual Health, a certification from the Menopause Society as a menopause medicine practitioner, as well as status as an advanced practitioner and optimal sexual experiences group couples therapy. She serves on the board of the Scientific Network on Family Sexual Health and Cancer and is a consultant to the University of Rochester's Pluta Breast Center's Sexual Wellness Clinic. She is founder and medical director for the Rochester Center for Sexual Wellness, providing comprehensive care for sexual, relational, and gender concerns in Western New York. Dr. Kranz is committed to educating healthcare professionals at all levels and the community on medical care for sexual concerns. Please join us for this informative and fun conversation. Hi, Pebble.
Hi, Patty.
I am so honored and excited to have you on the Self-Led in Bed podcast. And I get so many questions about health and the medical side of things related to sexuality and menopause and women's health and gender care. There's so many things that have a medical side to them. And often it feels like the world of medicine is so separate from the subjective person's experience
Mm.
navigating these very personal, aspects of their bodies and who they are. And I was so thrilled to hear of your work and your approach, which is so human and integrative. So I'm looking forward to lots of interesting conversation today. And I know my learning parts are here at the ready.
Hmm.
So wondering if you have any parts here as we're stepping in.
Well, I Certainly, there's always a nervous part, right? There's also always a part that just that I'm typically accused, which may not be the right word, but of having too much I want to share in too small a space. So I think that probably there's this um, enthusiastic, like wanting to have, to give you everything
Mhm.
part. Um, and then, I do think that uh, my parts show up in my personal life, and then in my professional life, I don't think about them so much. I'm sure they're there,
Mhm.
but
Yeah.
yeah.
Yeah. So, and sometimes those parts are so integral that they, especially with a professional role that is so aligned with who you are, I'm projecting there, but guessing that that might be the case, that you feel very much yourself when you're in your professional role. Is that true? Am I
Well,
making that up?
so that's super interesting because my career started in theater. And so where I was playing many different kinds of roles and not very often in myself. And as I became a physician, it was really and a primary care physician, I really sort of navigated this trying to find this professional identity to project.
Mm,
And as I moved into the work that I do now, I feel more and more just like it's being myself with regard to the conversations that I get to have with people. I get to be really curious about their internal physical worlds and their internal emotional and relational landscapes.
mhm,
I feel um, I feel that's changed over the course of
mhm,
my time as a physician.
mhm.
Um,
That makes so much sense, and I love hearing about that and how that has evolved for you. I'm wondering before we go further if you want to share geographically where you're located and maybe any other aspects of your identity that you would want people to know about.
sure. So I'm in Rochester, New York, in the middle of New York, far from New York City. um, and I am I'm a cisgender heterosexual. Actually, I'm a pansexual person who is in a heterosexual appearing monogamous ish relationship, and my my professional identity is a really important part of who I am. I'm uh, I'm very proud to be a sexual medicine specialist, and I'm very proud to be a menopause medicine specialist. And I'm also take great joy in doing gender affirming medical care as well. So those aspects of my identity are also really important to me.
Mm-hmm. Ah, thank you. And that would be a great segue then into saying a little bit more about your professional journey and the things that you're doing now.
Um, so as I mentioned before, I started out in theater, where I was really interested in people's stories. Um, and that evolved into an interest in becoming a medical doctor. I thought I was going to be a psychiatrist, but I ended up falling in love with all of the aspects of medicine, including delivering babies and taking care of diabetes and taking care of kids, and taking care of older adults. And so I decided to specialize in family medicine. And over the course of my time in family medicine, I had patients coming to me with sexual concerns, um, most of which, aside from some people with erectile dysfunction, uh, most of which I felt pretty unprepared to care for. And at the end of my training, I met my husband, who is a sex therapist. He was a sex therapist in training at the time, and he would tell me about the things that he was hearing from his patients about what doctors were saying to them about their sexual concerns. And I was sort of along with him saying, "Oh, gee, that's not right." That doesn't feel right. And then going with him to conferences, sex therapy conferences, where I really learned about how much harm uh, medical care is often doing to people's sexual well being, and how uncared for most medical patients feel with regard to their medical care for sexual concerns. And so that began this. Adventure of gathering education in this area through the European Society on Sexual Medicine, through the International Society for the Study of Women's Sexual Health, um, and uh, and then most recently through the Menopause Society, and other things too. It's one of those things that in medicine we get very little education about. So we get very little education in general medical care, no matter whether you're a primary care doctor who's a family physician or internal medicine physician, whether you're a gynecologist, whether you're a urologist, um, whether you're a psychiatrist. We, in general medical training, there is very little on sexual concerns beyond infectious disease and reproduction.
Mhm.
And so the process of getting this education was really one of cobbling things
Mhm.
together,
Mm.
which suits me because I love learning things. And if I could be in school forever, I would be.
So from what I know of you, I've seen that to be the case, just a thirst for knowledge and new things. And I just wanted to pause a minute just to really invite people to take in, and maybe for me to take in, the impact of what you're saying. And I've lived it and I've seen my clients live it. But I think hearing it from your mouth as a medical professional and your experience, it hits yet again that these people, who are well-meaning helpers that we turn to if something's happening with our body, are not trained and equipped to talk about, let alone have a nuanced interdisciplinary understanding of what the heck's going on.
Right, right. And you hit on one of the most important things, which is not prepared to talk about it.
Mhm.
Right. Because of all the cultural stigma, because of, the thing that is most inhibiting to most medical professionals is feeling like they don't know something. Right.
Mhm.
It's a group of
Right.
people that likes to be knowledgeable.
Uh-huh.
And if you feel like you're not resourceful in an area, you don't tend to ask about it.
Mm.
But the truth of the matter is that if medical providers are thinking with a little extra information, are thinking uh, creatively about what they know of physiology, that is true of so many other body systems, uh, there's there's so much more that people could be resourceful about, could
Mhm.
understand.
Mhm.
People, you put somebody on an antihistamine for their seasonal allergies, and they're complaining of sexual pain, right? Because it's drying out all their mucous membranes, right? If you're thinking, oh, yeah, the vagina and the vulva is a mucous membrane, just like the nose, they might be able to think,
Right.
huh, I wonder if that's having something to do with it. But I mean, this is a cultural problem. We
Right.
tend to sort of set aside sex
Mhm.
in
Right.
so many ways.
Exactly. And that's on top of the tendency to compartmentalize the body anyway, amongst different specialties and then really exiling the sexuality piece. While
Right.
you're on that subject, I did read some of the articles you had sent over. You're a wonderful writer, by the way. You have a bunch of articles on Medscape. And you pose because I think therapists have the same problem that we're not trained and hence often not so comfortable talking about these areas. And you listed three questions that you ask people. And now this is in your role as a sexual medicine specialist, which I will still ask you to explain to us a little better what it is. But you said I asked three key questions with regard to sexual function. What are your goals? What does sex mean to you? And what kinds of sexual play are important for you and possibly your partner's pleasure?
Yeah. Right. So I do think that when it comes to sexual well-being, we're always starting with what your goals are today. So that first question is always assuming all goes exactly as you wanted to with our work together. What would you like to see as the outcome? How will we know we succeeded? Because if we don't start there with a sense of their goals, then I could be trying to fix all kinds of things that aren't going to make them feel any more connected to themselves or their partners or their pleasure.
Mm-hmm.
Um, and then it's also informative with regard to what people's goals are. If they're focused on, well, I want to have my sexual experience. I'm 67. I want my sexual experience to be just like it was when I was 18. That's not we're just not going to be successful there, right? Because you've
Right.
evolved as a being, right?
Mm-hmm.
Your body has evolved. It could
Mm-hmm.
be even better at 67 than it was at 18. Often it is. But so it's helpful to start there.
Mm-hmm.
Um,
Yes, I love that. And the simplicity of the questions and the directness, and just like anything else that we do as mental health, if those of us, I know our listeners are not all therapists, some of them are. So whether we're in the therapist role or we're in the client role or patient role, these are questions we could reasonably wish our provider would ask, and we could suggest that they ask, right? If our
yeah,
doctors aren't asking that, can we talk a minute about what's important to me about this symptom I'm having or the
yeah,
thing that I'm wanting help with?
yeah. Well, and if you can come into your provider having already thought about what sex means to you, what sexual behaviors are important to you, um, then they're gonna they're gonna be better prepared, hopefully, to help you to know how important it is to you. So if you're
Hmm.
like, well, uh, I'm having this sexual pain, and the way that my partner and I get a reset is by sexual connection. Like, and if this is this glue that holds us together, our physical connection, um, it's really important that I get this sexual pain addressed,
Hmm.
right? Um, I I think that that's a different thing to say to a provider
Hmm.
than
Right.
I just don't know where the spark has
Hmm.
gone, right?
Yeah. I had a doctor tell me this was a gynecologist, and I was noticing with perimenopause and menopause a reduced level of desire. And I brought this up to the doctor, and she said, well, you're going to have an affair.
What?
She said the only thing that increases desire seems to be having a new partner. And I was, you know,
Okay. I mean, that
new
that
relationship
energy
energy,
is
that
fun, right?
could work, but I'm not
Right.
sure it's the only trick in the book. And just an example of, I knew enough to translate maybe what she was getting at and not run out there and get on
Right.
a website, but
Yeah.
I thought that was somewhat limited.
Yeah. Yeah.
But
I can't I can't believe how much I still hear from patients. I was told to have a glass of wine. I
Mhm,
was told that this was simply how it is with menopause.
mhm. Yeah.
This is just, this is just what happens with age.
Mhm,
Get used to it.
Yeah.
It's
So,
distressing.
so Pebble, maybe here you could just explain a little bit about the difference between so a like I went to a gynecologist for routine care.
Right.
Then there's a sexual medicine specialist and then a menopause specialist. And I know you said you cobbled things together. So I don't know if there's a standard definition of these things, but consumers are wanting to find someone like what's the difference?
Yeah. Um, so gynecologic training is a comprehensive training in women's health in many ways, but it still lacks training in sexual concerns beyond sort of the basics of sexual pain, reproduction, and infectious disease. Um, Broadly, this is true. Uh, and and then surprisingly, given the fact that all of their patients, hopefully will make it to their 50s and 60s, there's very little training in menopause. Um, and what we know about menopause medicine has really changed a lot over the last 15, 20 years. And uh, there's sort of a generational difference in how gynecologists and primary care doctors, family physicians also do well woman care, um, how there was training. So after the Women's Health Initiative results were put out there in the public, um, in I'm not sure if this is right, but 2002, I think, um, there
And
was
that was the study. Can you
uh,
just sum it? That was a
yes,
study that was
so
calling into question the safety of hormone replacement
estrogen.
therapy,
Yes, that's
estrogen.
right. Yes. So it had been it had been a common practice to provide an increasingly common practice prior to the distribution of some of the early results of that study to prescribe hormone therapy for people with menopausal symptoms. And After that study's results were published in a way that was really questionable, it was published in a news release rather than in a scientific journal, which would invite peer review, which would invite sort of a scientific conversation about the findings. And it was also published before the study was complete. Um, that just sort of one day stopped all the prescribing of menopausal hormone therapy uh, that had been commonplace before. And so there's this whole generation of physicians um, coming out of training from the early 2000s to quite recently um, that really learned that hormones were dangerous. And now, with a better look at the Women's Health Initiative, a better look at that overall study and its findings, better looks at other important studies with regard to the menopausal transition and the impact of hormonal treatments um, and the impact of menopausal symptoms, we now know that the story is much more nuanced and that if somebody is having a problematic menopausal transition, hormone therapy is very effective and helpful for a lot of people. And certainly, one aspect of that that is sort of bizarre that it hasn't been addressed is vulvar and vaginal health um, after menopause, which for the majority of people who go through the menopause transition, there is some change to the vaginal skin, the vulvar and the vaginal skin. Um, and when this is not treated, we not only get less lubrication and less arousal and changes to orgasm and sexual pain, but we also get increased UTIs and yeast infections. And so there are some sexual medicine specialists who would, and menopause medicine specialists who would say, this is life-preserving care to help people with their vulvar and vaginal skin. I got off totally on a tangent there.
But it was a good tangent. I mean, that's the, it was great. Yeah. And again, I want to invite listeners to notice their parts listening. Is this feel like something a million years off if you're a person with a vulva or vagina? Does this feel like relatable? Is this something you've been through yourself? What have your experiences been with medical providers?
Yeah.
Um, and and I want to talk further on this trajectory. And I just want to ask, do sexual medicine specialists also work with people with penises and
Yes,
male
absolutely.
sexual
Yeah.
systems?
Let me go back. Let me just
Okay.
take a little detour
Okay.
backwards.
Okay.
So a sexual medicine specialist is somebody who focuses on the sexual aspects of medical concerns and the medical aspects of sexual concerns. This is in the words of Dr. Charles Mosier, a sexual medicine specialist in San Francisco. Um, and there we don't have any certification here in the United States for people who are specialists in this field. It's a field of medicine. It's um, a, a zone of knowledge around sexual function and dysfunction, as well as gender concerns, and also has a biopsychosocial basis. So attention to biomedical components, physical components, as well as psychological, relational, social, and cultural components.
Hmm.
So in Europe, they do have a certification for board certification for sexual medicine, but we do not have that here. So in the United States, largely people who are calling themselves sexual medicine specialists are just saying, hey, I've done some extra research in this area. I've done some extra learning. If somebody is a fellow of the European Committee on Sexual Medicine, that's that European fellowship, or they may be a fellow of the International Society for the Study of Women's Sexual Health, an IF,
Hmm.
uh,
Hmm.
and that indicates a certain level of knowledge about sexual concerns. And yes, this is across genders, all people. Um, I would say that I take care of pretty much 50% uh, people who are people with penises and 50% people who are people with vulvas and vaginas. Today was a majority penises day, right?
Hmm.
And
Hmm.
other days are a majority vaginas day.
Hmm. Hmm.
Yeah,
Okay. And
yeah.
do you work with non-binary or transitioning people too?
I do. I work with a lot of people who have complex medical issues that impact their gender affirming care, or uh, people who are sort of looking for kind of a more collaborative, nuanced approach with regard to their gender affirming care, because I'm in this collaborative setting where I'm working closely with gender and sex therapists.
Great. Yeah. So thank you for clarifying that. And that highlights the place that culture plays, right? Like, how could it be that there's an entire medical specialization in Europe that we don't even have here, and we could go into that too, just the attitudes, and how those can vary from country to country, culture to culture, subculture. I want to get back to the menopause stuff, but that, I don't know if you want to comment at all on what you see in terms of the cultural element here before we go to the menopause piece.
Well, I mean, so stigma and this sort of setting apart of sex absolutely plays a role here. And we here in the United States have a very complex relationship with sex. It's like it's everything and it is not happening, right, all at the same time. So there's that cultural component. But then, we also have a history of fields in the medical culture. We have a history of fields of medicine coming to light eventually. So palliative care is a field of medicine that was not much spoken of 50 years ago, right? It certainly was just beginning when I was in medical training. And then geriatrics as a field, right? Hopefully we all get old, right?
Right,
But
right.
that's a new field of medicine. Sleep
Mhm.
medicine is a new field of medicine. So
Mhm.
this happens in the medical culture, that there's a realization that there's a gap,
Mhm.
um, and sort of a field of medicine develops around it.
Mhm. Great.
Yeah.
So then that takes us perhaps back to being a menopause specialist, and um, curious, what are some things that maybe people don't recognize as aspects of perimenopause or menopause? Um, this,
Yeah. So
I feel like there's lots on this subject. So if you want to jump in a different way to that topic, you may. But I've noticed sometimes I'm like, oh gosh, no one told me about that one. Or, some people have things that, are not obvious signs of that.
right, right. So this is all of the symptoms of perimenopause are could be something else, right?
Mhm.
So that's it gets
Mhm.
confusing
Right.
for a lot
Even
of
perimenopause, if you could say, even
what that is,
what
right?
that is. Yeah.
Yeah. So I think that we need to, before defining perimenopause, we need to define menopause. So
Mhm.
menopause is this whole transition from before from early perimenopause, when uh, the hormone production and the eggs available in ovaries uh, are declining, and when hormones are very erratic, to the last menstrual period, which is where what we sort of think of as the marker, the important marker. And then 12 months after that last menstrual period is still perimenopause. It's part of this menopausal transition. And at a year after the last menstrual period is when we say that is the definition of menopause, but it's actually this whole span of time
Mhm.
from um, from erratic period, the decline of eggs from the ovaries, and erratic hormone levels, to early post-menopause, which is the first 8 years of after the last menstrual period, and then later postmenopause. Beyond that, all of that is menopause. So it's really this swath of time, more than a set thing. So perimenopause then is that early time, and then that first year after the last menstrual period. And
And it could start earlier, right? That people sometimes recognize some of that those
absolutely,
shifts.
yeah. So the average age of menopause is 51. The average age of a year after the final menstrual period is 51, but it can happen anywhere between 40 and 58. And if it's before that, it's early menopause before 45 and premature menopause before 40. So those symptoms that occur before where we say menopause happens is there are the time of the most symptoms tends to be the 1 to 3 years before that final menstrual period, but it can stretch for years longer than that, right? So there's some people who have perimenopausal symptoms, but it's still 7 years off that they have their final period.
And so the commonly known ones are things like hot flashes and moodiness, maybe. There's things. So wondering, what you might say, people might be experiencing something and maybe even emotional things and not connecting the dots in the early
Right.
stages.
Yeah. A lot of people just feel like, oh, I'm no longer myself. I don't know myself, right? Um, or just feeling off, right? That's the most common menopausal complaint. I just don't feel like myself.
Oh, how interesting.
Yeah.
And
So
from an IFS perspective, I'm thinking about self also, be self-led in bed, but wait, where is myself? I
right,
used to know where that was and who that was.
right. Yes. Yeah. It's very much like puberty, where there are these, huge internal changes. And so what you knew of yourself when you were 9, some of us had the benefit of knowing ourselves really well when we were kids, right? Like having had settings in which there were, there was the opportunity to really know oneself, and not everybody had that. But for those who did, then puberty comes along and it just throws all the cards in the air about who you are.
Right.
And
I don't know. My body's doing things that are unpredictable and I'm growing and I'm out of control and all the moods. And now I'm all of a sudden wanting to look at people in a different way than I used to and
right.
all
And
that, right?
so irritated by my parents. It's
Yeah.
unbelievable,
Yeah.
right? Yeah.
So
My
can you
body
talk
odor.
about, body odor changes. So then I'm my parts are so excited to then, like, I felt, I noticed I had like my adolescent parts and these really rebellious, like, crony parts were like ganging up together. They weren't crone parts yet, but kind of like, I don't know, just
Yeah.
angry, getting angry, like enough with everything I've been doing
Right.
that is serving
Right.
serving others.
Yes. Right. Yeah. Yeah. That sort of sense of, so what comes to mind is two things that I hear from people a lot. One is, um, you know, the, the things that you never thought were irritating to you all of a sudden become profoundly irritating. And the other thing that can happen with hot flashes that I hear from a lot of people is, you know, like, I didn't know I was pissed off when my boss talked to me in this particular way. And now that I get hot flashes, it is perfectly clear to me that what is happening is that I don't feel this is right and I'm pissed off, right?
Mm.
Because my body is just having this response
Yeah.
um, that is related to stress levels going up and being uh, activated, right?
Mhm. Mm.
Not that it's just about that. It's a physiologic thing
Right. So
that
this is where
happens
I
in
think
the
we
brain.
have this intersection, right, of this biological process, but then the way our parts or our, the way we've adapted to our life roles and positions and things, maybe we
Mhm.
start to not be able to tolerate the same adaptations, or we
Right.
don't have the patience, or we don't have, I almost feel like there's not as much buffer, like, you're talking about tissues thinning and things like that, but it almost feels like at an emotional level, there's maybe a little bit less padding on,
Yes.
how much we feel things or react to things,
Yes, absolutely. I
which
love.
can bring clarity, a lot of empowerment and clarity,
Yeah. Yeah.
but
Yeah.
it can also be a little difficult on the family members.
Right. And on the self, if you're like, wait, I'm not a person who gets flustered by things. Yeah.
Hmm.
Wait, I'm a person who prides myself um, you know, on my sense of caretaking, right?
Hmm. Right.
Yeah.
So that could be, yeah, where when I think in parts, it's sort of like maybe the parts that have been leading maybe get bumped out of the way,
Right.
and then there's a disorientation. And not that those weren't authentic or aren't still really important, but there might be this reorganization that happens.
Right. Right.
Yeah.
Yeah.
Pebble, can you comment on brain fog?
Yes.
Is that a real thing?
It is a real thing. It is a real thing. So, uh, so one of the things that happens in the menopausal transition, sometimes along with hot flashes and night sweats, is sleep disruption, and uh, and sleep getting not only disrupted by more frequent waking, but also not getting deeper sleep. We also see an increase with the hormonal changes in some sleep disorders. So, sleep apnea can get worse. Um, Restless legs can get worse with the changes in menopause, um, and the brain fog is thought to be in part related to the sleep disruption that occurs, and oftentimes people don't know that their sleep is disrupted. They're not really aware of a night sweat, but they're just waking up thinking about things, right? They're
Mhm.
more often, yeah, or having a harder time getting back to sleep.
Mhm.
So those sleep changes are one important contributor.
Mhm.
The other thing that we do see that's super interesting with menopause is there is a particular kind of memory that is impacted by these hormonal shifts, and that's verbal memory. So, memory that is about finding words, or memory that is about learning new things. And those um, those are things that can shift even in the absence of disrupted sleep, is my
Mhm.
understanding.
Mhm.
Um, this change in verbal memory, which can be incredibly disorienting.
Is that like when you can't think of the word?
Yeah, yeah, yeah. Like, I know that I'm talking about an apple. I know I'm saying, get me the apple, right? Right? It's disorienting. We like it. I think it contributes to that sense of not knowing ourselves.
Mhm.
Um, So
feeling out of control, maybe.
yeah, yeah.
Yeah.
And then a lot more effort to speaking. Like in my uh earlier menopause time, in my perimenopause, when verbal memory was really a problem for me, I was so stressed about having to give a talk,
Mhm.
right?
Mhm.
Being able to express myself, that I think that that can contribute to this sense of fogginess as well,
Mhm. Yeah.
more
Yeah.
mental load. Yeah.
And for folks who may have some form of neurodiversity already, maybe with ADHD or they're autistic or they're having some processing differences, it seems like there can be an exacerbation there.
So we do very commonly see more attentional challenges for pretty much everybody around the menopause transition, right? Um, whether it's somebody who has had attentional um, challenges or difficulties or neurodiversity um, prior or not, right? Attention becomes more challenging. Um, and, and I think that question of like mental load too. I think living in this world with neurodiversity requires this uh, profound mental load already. All of uh, the accommodation that the world requests of or demands
Mhm.
um, of people. And then you have this additional mental load on top of it and inadequate rest. And,
Mhm.
I think that is something that it is additionally hard. Yeah.
Mhm. Yeah.
Yeah.
Yeah. And on the other hand, there can be some relief, right? Sometimes there's like, what do you see some people saying are like, gosh, now I'm more able to concentrate on some things because I'm not having
Where
maybe
yeah.
my libido is a little quieter and I'm actually more able to focus on other things,
Yeah.
or I'm maybe at a time in life where I don't have as much responsibility. I mean, depending how old people are, if they have children
Yeah.
and how this hits, that can have an impact too. If you're parenting teens and they're in their adolescent transition and you're in your menopausal transition, that could be exciting.
Right. Right.
So or maybe your kids have already left and or you don't have children. So that in terms of, I guess I'm thinking of load, mental load,
Yeah. Right.
and life circumstances would affect that quite a bit.
Yeah. Yeah. And in some ways, this is a time where there's a lot more clarity sometimes about one's priorities,
Mhm.
uh, clarity about what one wants
Mhm.
with regard
Yeah.
to relationships and what
Mhm.
one's willing to put up with.
Yeah.
Yeah.
I mean, I feel like it can be a bit, again, like adolescence in a way, because I work with a lot of women who they get to this point in time and there's like, I've had it, like there's been a certain quid pro quo or what's the word, status quo.
Yeah.
And there can be almost like just like a part, I'm going to say, that's just
Uh-huh.
like no more and can perhaps even make an impulsive decision or have an affair or end a relationship. And sometimes that's a self-led decision. Like now I have the discernment, I'm more confident in myself, I'm
Right.
maybe more established financially. I'm in a place where I can say no to this thing and am choosing a growthful direction for myself.
Right.
And sometimes it feels like maybe very part driven, just this firefightery. So I just like I have this I just
Yeah.
can't
I gotta
stand
get out
it.
of
I
here.
got to get
Yeah.
out of here. I'm done. Um, and I'm just wondering if does that resonate at all for you that people,
Mm.
maybe in certain moments be in a place maybe where they're more, I don't know, maybe more part led or biologic, hormonally led. And that could be clear. That could be a good energy to amplify a decision that was hard to make or make a move that was hard to make. But
Right.
um, just wondering from your vantage point, if you could comment on that at all.
Yeah, I mean, that's a really interesting thing. Um, I, I certainly, I certainly hear that at times that, there's sort of a settling into oneself and it's clear, you know, this is, this is what is okay with me now.
Mhm.
This is what is not okay with me now. And, uh, a clarity around boundaries and desires. Um, when I'm typically seeing people, they're in a degree of distress, right? I don't always get to uh, see people. I mean, I see people through their concern until we've reached their goals.
Mhm.
Um, uh, but I suspect I talk to a lot more firefighters and protectors and managers
Uh-huh.
uh,
Yeah.
than always self-led. But I
Mhm.
do, I think it is something that I, try to be attuned to,
Mhm.
particularly with regard to when I do physical exams for a concern. Um, are they in a calm, curious place, right?
Mhm. Mhm.
Is uh, are they and if they're not in a place where they're expressing curiosity, confidence about their ability to engage in the exam or the part of the exam that
Mhm.
we're talking about doing, I'm like, I'm not, we're not, we're not going there unless you're
Mhm.
in that curious space.
Mhm. Yeah. And I'm glad you're bringing that in. So we have number one, all these parts, that may be related to the menopausal transition
Hmm.
and how that, there's lots that can be going on then. One last thing I want to say on that, and then I want to get into this other area, which you also have been doing some really interesting work in around exams, the clinical exams.
Yeah.
So just, that one other factor is the sense that if my childbearing years are over, it's a sense of really taking stock of where I am in the lifespan. So it's not
Right.
all the hormonally driven stuff, but kind of a reckoning with, okay, like all of a sudden I'm seeing I'm, probably past the halfway point here or
Right.
getting close to that. And that's some of the clarity can come
Yeah.
from, that place.
Yeah. Knowing what your values and your priorities are. I think
Yeah.
one thing that is super interesting is in studies of uh, both men and women. So these were studies in cisgender folks. Um, uh, while there are more um, reports of problems with arousal, problems with orgasm, problem of changes in desire. As people age, there's also less distress about
Mm.
those changes. And
Hmm.
so there also may be clarity around that, where uh, people are, are living hopefully a more um, integrated uh, values and clarity
Mhm.
driven uh, sexual life where they might have thrown out the sexual script
Mm-hmm.
and figured out how to get their touching needs and their sexual outlet needs met in ways that don't have to include a lubricated vagina, an erect penis, orgasm that happens in a particular way, right? So
Mm-hmm.
um, that is one of the um, real benefits of this period of time as we get older is that uh, there there can be more clarity and enjoyment than
Mm-hmm.
about things that might not be exactly the way they were when we were 18.
Mm-hmm. Yeah, I'm so glad you brought that up because I think that, and I've seen, studies around that. I think you've studied the optimal sexual
Yes,
experiences
yeah.
work. That's Peggy Klein-Platz and
A. Dana Menard
Dana Menard.
wrote
So
Magnificent Sex. Yeah.
Magnificent Sex, and spoke with many long-term, older people, some of whom in long-term partnerships, many of whom said that they were having the best and most intimate sexual encounters, of their lives as they were older, and that, really prioritizing connection and communication and intimacy and authenticity and um,
Right.
and all those. I talk a lot in my work about all the parts that show up in bed. We're rarely alone there, even when we're alone, right? Because all the parts that come in, maybe criticizing our bodies or
Yeah.
about our performance or wishing it was different, or I had a partner, or I didn't have this partner, I had a different partner, or all those parts. And that
Yeah.
there can be a time where sometimes it's a little easier to say, I'm here and I'm happy to be in this moment, and I'm gonna be with myself and my body parts and my emotional parts and appreciating this day.
Yeah.
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 So I had the good fortune of seeing you present at the recent STAR conference, and you had a very interesting topic. And I just wondered if you'd want to, it sounded like maybe where you were going a minute ago would be a good transition to talking about that.
Yeah, well, this is one of the areas of my work that I find um, most rewarding right now. Um, all my work is rewarding, but this is something that gives me great joy. I've had a handful of people come to me, uh, not so much because of sexual concerns, but because they have been unable to um, have pelvic exams without a great deal of distress. Um, some with psychogenic seizures in the wake of pelvic exams, some who are just unable to even think about making an appointment for a pelvic
Mm,
exam, um, uh, related to traumas that uh, maybe traumas that happened in a medical setting or traumas that are happened outside of a medical setting or a combination.
mhm,
um, and while we talk a lot about trauma informed principles in medical care, we talk some about that. Uh, and there's an increasing in awareness of trauma informed principles. We don't really have a good way to help people who have had really traumatic medical experiences get back to being able to have routine medical care.
mhm,
And so I have been working on this protocol to help people um, move through a process in order to be able to have pelvic exams with confidence and be able to advocate for their needs with other medical providers uh, and and one of the components of the protocol is really relying on a lot of IFS language, and recognition that there are parts that reside in the body that are coming into play when we're presenting for medical care, and that they're sometimes in conflict with other parts that want to get medical care, want a question answered, want a problem resolved. So that's one of the frames that I think about when I'm thinking about this protocol. But what's been really fascinating to me is that some of the principles that I have learned from working with these folks, I use with um, all of my patients, and um, and the responses are um, moving and remarkable. um, because so whenever I talk about an exam, first I say, here, I want you, before we even consider doing an exam, I want us to talk about the principles of the exam, and exactly what would happen in the exam room. And the principles of any exam that I do are, first, that we only ever do an exam if it's going to answer a question that you have. So you need to be in that curious place, right?
I love that. Yeah.
Um, and secondly, uh, you are in charge of absolutely everything that happens in the exam room. And I'm going to cheer if you advocate for yourself in any way at all. If you want a blanket, if you want me to cover a poster, if you want me to find new plants to put in the room, if you want music, I am going to cheer. I'm going to do everything possible to make that environment feel welcoming to you. If you want to bring in a support person, I'm going to be very happy for anything that you do to be in charge of that exam room, and also to be in charge of me. I want you to know that all of my actions in the exam room are going to be under your control, including the ability to say slow down or stop at any time. If you say slow down or stop, that is exactly what is going to happen. Um, and then the third principle is that no enduring is allowed. So there's no white knuckling it through any component of the exam. And that's on a physical level as well as an emotional and a mental level. And then after we describe these principles, I describe exactly what would happen in the exam room. And what is moving and remarkable to me is that the vast majority of my female patients say, often tearfully, why isn't it always this way? How come this can't always be the case? That you do what that you're doing this as a service to me, that I'm not allowed to endure things, I'm not going to be asked to white knuckle it through things, that I'm in charge. Why can't it always be this?
Listening to you describe your principles was kind of jaw-dropping. Like, both, that feels so good. Like, just picturing all these scenarios, even beyond a pelvic exam, where it would make me feel so cared for and safe, and human, like I'm being seen as a human being and not just, a vulva or a lung or something.
Yeah.
And then, yeah, then the second question is like, this shouldn't be radical. This should be normative.
Right. Yeah, so there are lots of systemic factors that make it very hard
Mhm.
to, provide care in this way. Most medical providers are coming into medicine because we want to be of service to other people. And then all of the medical system is pretty much made up so that it seems like everything is of service to the medical provider.
Mhm.
And there's
Or the whoever's making the most money off of this, which
right,
may not be the providers
right, and
either.
that's true. That's true.
Yeah.
Yeah. And so, and the power dynamics that are at play and how
Yeah.
we've engaged with medical care, um, you know, from the
Mhm.
time we're, little kids getting shots, right?
Mhm.
Getting our ears looked in, which doesn't feel good.
Yeah. Yeah.
Yeah.
Yeah, and this whole question of, yeah, what are our body boundaries? Who's in charge of them? And,
Yes. Yeah.
somehow doctors are assumed to be safe people. And of
They're
course, there's
not
the
all.
doctors who really cross the line.
Yeah.
The,
Right. Yeah.
but small number of bad, really, bad actors. But then the majority, like you said, are people who are wanting to provide care, but they're in a system that maybe do you work in a private setting or, some people have very short windows in which they
Yeah.
can work
Right.
with their patients.
Yeah. I mean, I see my first visit with people is typically 90 minutes long. My follow-up visits are, a generous 45 minutes.
Hmm.
So that most people don't have the luxury to say that they provide that kind
Hmm.
of care. And within
Yeah.
an insurance system,
Hmm.
it would be impossible because
Yeah.
I would not be able to keep my doors open
Hmm.
to be,
Yeah. So
yeah,
we see just, yeah, how best practices and then these other constraints can interact, have a difficult relationship. And then as someone who's coming in with trauma or, medical trauma or some kind of personal relationship
yeah,
trauma, um, that can be a tough spot to be in. And I think,
yeah,
therapists in their offices can help clients and that IFS can really be helpful, at least and sorting out those parts, and trying to find the voice, the person's voice so that they
right,
can at least, advocate for themselves
yeah,
and say no to things, that are not okay.
yeah.
Yeah.
And most of the time, people can make enormous strides in talk therapy with regard to getting care.
Hmm.
Being able to get back to medical care that was previously very difficult for them or
Hmm.
distressing. But
Yeah.
I think then there are some times where an experiential uh, environment um, is necessary to build the
Hmm.
evidence base.
Hmm.
I talk about that a lot with clients. Like with sex, if
Yeah.
you've had 13 years of painful sex,
Hmm.
you're going to need to build an evidence base around pleasurable sex
Hmm.
before any part of you is going to believe that sex is going to feel good,
Hmm.
right?
Right. Right. So those, and I do a lot of similar work with people around their protector parts and really appreciating why they're flaring as they are,
Yeah, yeah,
and
yeah,
yeah, I love that, just it's going to take time and that trust has to be developed.
yeah.
And there's a lot of components that go into that. So I'm wondering if there's any quick tips you would want to offer. These are, of course, nuanced subjects. We've kind of
Yeah. Oh,
traversed a lot of territory, whether it's about, um, you know, self-care related to the menopausal transition or some, anything else we've spoken about. Just wondering if you want to at least direct people maybe toward a few resources.
Sure. Uh, Resources, definitely listen to the Self-Led in Bed podcast. Go to Patty Rich's workshops. um, I think that the takeaway that I would want people to come away with is, with regard to both menopausal difficulties in the menopause transition, and sexual concerns. Um, Very often, there are some biomedical solutions that exist. And if you have an experience, particularly around sexual pain, um, keep on looking for medical care until you get the care you need, um, no matter what your age is.
Mhm.
This is something that it always has a component of being in the body. You can't think your way out of sexual pain the vast majority of time.
Mhm.
So solutions, for a wide variety of sexual concerns exist. Um, I think that it's also really important for us to use all of our, I use any opportunity I can to have people think about what feels good in this body now,
Mm.
and really having a pleasure practice that allows you to pay attention to all of your body's pleasure experience as it is now. And you can love the pleasure experiences of the past, but um, the pleasure experiences in this body now, and then what feels good with another body right now. It's not necessarily going to be the same thing that felt good with another body uh, 20 years ago, or 10 years ago, or 3 years ago, right? So, um, throwing out the sexual script and really thinking about your present moment, having access to your present moment experience in your body is the only sexual skill that
Mhm.
anybody needs.
Mm. Love that. Yeah.
Good.
Yeah. And I know we'll be sharing some resources in the show notes that in terms of getting in touch with you or some other organizations that you've mentioned today.
Oh, great.
Yeah.
Well,
There's one last question I like to ask people, which is on a more personal level, if you want to share anything that gives you pleasure in this body now. Maybe not now, but anything you'd want to share, just that, you find enjoyable or
yeah,
pleasurable.
yeah. Um, well, uh, I take great pleasure in having coffee on my porch, listening to the Purple Martins and looking at Lake Ontario. That is a deep, deep pleasure for me. Um, and then just, as I advise, I try to do the same thing myself. It's not always so easy to notice and appreciate what just feels good in this moment now. And right now, at this moment right here, I'm enjoying seeing you and that beautiful color blue behind you, and just really loving always the conversations we have.
Hmm. Well, thank you, Pebble. I could say the same. You're just such a lovely person and a wealth of compassionate and scientific knowledge. And I'm really grateful here that you were here today. And I could imagine further conversations if you're ever willing to visit again.
I'd be
And
happy to.
yeah, awesome. Well, thank you so much. Bye bye.
Thank you. Bye.
Thank you for listening to the Self-Led in Bed podcast. Check us out at www.patriciarich.com/podcast, where you can sign up for a free guide to the 6 S's of sexual self-energy. And if you liked this episode, please subscribe and share it with a friend. Until next time.